So I'll be talking about our research on the workforces providing abortion and contraception care in the US. We've had a number of papers and health affairs, I always keep wanting to call them health affairs blogs, but health affairs forefront posts that have come out of this work. I'll be particularly talking about 4 of them. I'm also happy to share links for any of them at the end. I will say, I wanted to just do sort of a quick introduction on some of the underlying principles behind this work. So traditionally in public health, we have focused on preventing outcomes that are often perceived as adverse outcomes. So unintended pregnancy, teen pregnancy, abortion. And what that has resulted in, and this is something that the research had shown, is that providers, clinicians have focused on the efficacy of contraceptive methods rather than on patient preferences around contraceptive methods. And so for a while, providers were encouraged to use a LARC first or long-acting reversible contraceptive method approach to contraceptive counseling rather than reflecting the needs of the patient. Some research has also found that providers, especially given this sort of framework, are more likely to pressure women of color and low-income women to use longer-acting methods which are more effective and to limit their childbearing. We know that there's a history of bias in general in healthcare, but particularly in this space. And so when we take this in the context of a history of coercion around reproductive healthcare, that includes forced sterilization by the medical community, we want to always think about this sort of in our framing. And so we believe that access to reproductive healthcare is a significant health equity issue and that healthcare providers can play a critical role in determining that access. So this research aims to answer kind of this broad question: who is providing reproductive health services and to which populations across the United States? We use a number of different large data sets. I'm going to primarily be talking about these 2 that are classified here under services. I am happy to answer questions at any point about the other ones that I've listed here. I'll just sort of briefly mention what each of these are. So IQVIA is a private data company. You have to pay to get their data. We have purchased from them both medical and prescription claims data from 2019, 2020, and 2021. We are in the process of cleaning our 2022 data. And that's one of the main data sets that I'll be talking about today. More recently, we have also gotten TMSIS Medicaid claims data. There's a little bit of a lag time for when that is becomes available. So we have 2016 through 2019, and we're working our way through cleaning the 2020 data. So that sort of helps us understand what services are being offered by whom and in some cases to whom. For additional, oh, yes.
Can I just ask a clarifying question about that IQVIA
Yes.
data? Is this a collection of across health insurance providers, a single provider?
Yeah.
Can you tell us anything more about those sort of population you're drawing?
Yes, and I will also be
okay.
talking about on the next slide, but I'm happy to answer your question. It has, well, if it's okay, I'll go to the next one and then come back to your question. Just to real quick kind of talk about these other ones. So the American Medical Association master file and a historical residency file has additional details on where physicians did their residency training. For certain analyses, we use the National Plan and Provider Enumeration System, the NPPES data, which has limited information, but information on all providers who conduct HIPAA-covered transactions in the United States. And then for some of our analysis specifically related to pharmacist prescribing, we use the Bureau of Labor Statistics, occupational statistics data. And then to understand the population that could be receiving services, we use the Census Bureau American Community Survey data. So I'm going to be talking about IQVIA data first, because the first couple of papers we use IQVIA data for. So IQVIA is derived from 3 types of sources: billing software, which usually is the electronic health record at a provider office, claims clearinghouses, as well as insurers. And to answer your question, it does have commercial insurance, Medicaid. On the prescription side, we have self-pay as well. We have other insurance types like TRICARE. We mostly have focused on commercial and Medicaid, but we include everybody here. Did I answer your question?
I'm just trying to get a sense of how representative. Does it represent like certain types of people? You know, like what is the?
So IQVIA says that they have information on 191 million patients in the US. They say on their prescription claims side, which is a little bit stronger, they say that they're capturing between 92 and 94% of prescription claims files. The variation there is basically what year of data. So it's 92% in 2019, it's 94% in 2021. On the medical claims side, it's a little bit less comprehensive. They say that they're covering 84% of AMA registered physicians It's not as good on the advanced practice clinician side. Now, I will tell you, since we're in California, we know that Kaiser is missing.
Oh,
They do not capture information on Kaiser because the only people who know what Kaiser is doing is Kaiser, basically. So we know we're missing that. That's, is a limitation of the data. But
So you think you're missing sort of a handful of like large insurers like
Large
Kaiser,
insurer.
so.
and maybe Geisinger also,
Okay.
but yeah. And then I think what we understand that the other places we might be missing on the pharmacy side is like small, probably mostly rural pharmacies that don't work with sort of a big like claims clearinghouse, but like CVS and Walgreens, I'm sure we have, but if you're maybe a standalone pharmacy, we might not be capturing every single one.
Apart from the coverage, do you have any sense of the accuracy of the data?
Yeah, so on the prescription side, it's pulled directly from the pharmacy clearinghouse. So there's no, so we suspect that it's fairly accurate on the prescription side. On the medical claims side, there is variation in the comprehensiveness of the data that we're getting. That is reported to us by IQVIA. So for each of the providers that are in their data set, they classify them as one of 3 tiers of sort of comprehensiveness of the claims. So tier 1 is the best, tier 3 is the worst. And the way that they sort of explain it to us is if you're a tier 1 provider, they're expecting to be capturing all of the claims that that particular provider is offering. And if you're tier 2 or tier 3, then we are likely missing some of the claim services. So for example, all advanced practice clinicians are in that tier 3 category. So if in real life, someone provided 10 IUDs in a year, if they're a tier 1 provider, we expect that we're getting 10 IUD claims in our data. If they're a tier 2 provider, we might be getting 6 to 8. We don't know for sure which ones we're not getting. And if they're tier 3, we might have 0, we might have 1. And so it depends, it's sort of classified by the specific provider within their system. So, yeah.
You have a sense of how many, what fraction of the data come from the first tier, what fraction might come from the second or third tier?
Yeah, I would have to double check. So one of the challenges, so let me, if you can hold that for just while I do this one bullet point and then we'll come back to it. So on the, so both for medical and prescription claims side, we have them identified at the provider month level. So that means we have their provider's name, their NPI, which is their national provider identifier, their specialty, their mailing address, and a couple of other details. So what we don't have is the patient information side of things. So the other PI on this project is Candace Chen. She's a physician, so she's my sort of go-to example. So for Candace, in the data, I can see her name, I can see her NPI, her specialty, her mailing address. I could see that if she put in 10 IUDs last year, I could see that. But I could not see that she provided 1 IUD to Julia Strasser. I could not see that she provided 1 IUD to Julia Strasser and then a prescription to Julia Strasser later on. I completely forgot what your question was, but I think I remember that I was going to answer it. So can you say it again? I'm sorry.
What is the fraction of the data that
Oh,
comes
yeah,
for each of the
Right.
tiers?
So we have the provider information identified at the month level. And so each month they might be in a different tier. So there's variation across the year and then there's variation like within each year of the data. But in general, most of the data that we have, I think somewhere on the order of 40% of the providers in our sample were tier 1 providers, and then the other half were tier 2 or tier 3.
Right.
But it changes sort of, so you have people who are always tier 1 for the whole year, people who were tier 1 for 10 months out of the year. So a little bit kind of like varies throughout the data.
How did you define tier?
The IQVIA provides that to us. We haven't defined it.
So how did they define this person, this provider is tier 1 or tier 3?
So I think it depends for them. It's based on the supplier of the data that comes to them. So they know that certain EHRs or certain claims clearinghouses are providing them, or certain insurers are providing them the full scope of sort of the full volume of services that the provider is doing that year. And that certain other ones aren't necessarily sharing all of them, or there's some kind of data sharing issue where they can't get all of that information. So using both our prescription and our medical claims data, that is how we have defined the workforce. So sometimes in the past, research on the workforce has focused particularly on a subset of providers, for example, OBGYNs, or has relied on surveys. I love surveys, have used surveys a lot. This is not a knock on surveys. but it's harder to get a picture of the national workforce if you're using survey data. So I'm going to talk about this paper first. I'd like to note this particular author. She's sitting right there. We lost her. She came here. She's great. It's gonna work out. I will say I didn't, so I have, for each of these papers, I've done sort of a brief purpose and sort of research aim, then some of the results, and then I have all of my discussion points kind of for everything at the end. So I'm doing it in a little bit of a different structure than a traditional paper is. And all of these are observational data. I was reminded that there are a number of economists. This is not causal. I just want to say that up front. This is all observational data. So, like I said, a lot of research in the past looking at the national workforce has faced data limitations, like focusing on a particular subset of providers, relying on survey data. And so no one has been able to study this workforce at the national level. And so we used our prescription and medical claims data from IQVIA to understand the workforce that's providing contraception services in the US. These are the tables from the paper. I find these very hard to look at in PowerPoint format, so I'm going to walk through them sort of slowly. So again, just to give you sort of a sense of the scale of the data set that we have, there are about 1.8 million prescribers of any medication in the IQVIA data. And among those, we identified 289,000 or so who are prescribing contraception, so the pill, patch, or ring. And then what did that look like in terms of specialty? This is one of the things that we were trying to understand with our data. So we were expecting OBGYNs to have a high number of prescribers. We did find that 73% of OBGYNs across the US are prescribing pill, patch, and ring. We found that family medicine physicians, about half are prescribing, a little less than 20% of internal medicine. Sorry, I realize I don't have abbreviation explanations up here, but family medicine, internal medicine, a little more than a third of peds. We know, again, that advanced practice clinicians can prescribe as well. APRNs typically includes nurse midwives, but we have pulled those out sort of separately because for this analysis, because of their focus on women's health in particular. And so we found a similar proportion of nurse midwives and of OBGYNs who were prescribing contraception, and then about 20% of PAs. So this is when you look at it sort of as a proportion across the whole US. When you look at the number of providers, we see actually that even though only a little more than 50% of family medicine are prescribing, that it's actually 72,000 people. So there are way more family medicine prescribers than there are OBGYNs. And then similarly, I want to share the same thing about advanced practice nurses. So when we look at the total workforce, we see high proportions of OBGYNs and nurse midwives, but then large numbers of family medicine and advanced practice nurses. Going back to the issue of sort of the tiers, we wanted to focus on the subset of clinicians where we had the most accurate claims data available. And so we chose only providers who were tier 1 in every month for the full year that we were looking at. So that gave us a sample size of 61,000. It's much smaller than our prescription size. But we wanted to do this to understand who was providing care and who wasn't for the IUD, the contraceptive method, and the depot shot, which is also sometimes called DMPA or the injectable. So to be in this sample, you had to be a tier 1 provider in the IQVIA data and be providing some type of contraceptive care already. So this is the straight numbers. We have about 21,000 providers of the shot, fewer providers of IUD, and even fewer providers of implant. And again, we wanted to look at this as a breakdown by specialty. So we find that similar proportions of OBGYNs and family medicine were providing depot, a little about half or each. And again, similarly, from the prescription data, we found that about a third of internal medicine and pediatrician were providing depot. When we look at IUD, it looks a bit different. So we found almost at all OBGYNs in our sample, 92.8% were providing IUD services. We found way lower percentages of family medicine providing IUD as compared to depot, and then low proportions of internal medicine and pediatricians as well. And then for the implant, we found it looks a little bit more similar to the depot shot for OBGYNs. Family medicine, it looks similar to IUD, internal medicine, pretty small proportions. I wanted to note about pediatricians because for all of the provider types, except for pediatricians, we find lower proportions that are providing implant compared to IUD, but for pediatricians, it's the reverse. And we know from other research that adolescents who might be more likely to be treated by a pediatrician often choose implant over IUD. And so we recognize that it's two sides of the coin, right? Is what are the providers offering and what are the patients requesting? So we know that there's an element of patient preference here. I think this is a particularly sort of evident example. Yeah.
It's kind of a naive question. So across all states, are all of these different classifications of providers able to provide all of the range of contraceptive methods you're talking about?
Yes.
Okay,
Sometimes for advanced practice nurses and PAs, they have to have sort of physician supervision for some of them, but we know that looks different in practice. Sometimes it might just be like an MD signing off on the chart at the end of the day, not necessarily that they have to be in the exam room, but we know for advanced practice
or they
clinicians.
themselves, the supervising provider is trained as well. Do they have to
Right.
also be trained?
I don't know. I suspect that it's different state by state because
state.
so much of this is determined at the state level for
Right.
scope of practice for advanced practice folks. Yes, and then yes. No.
Wait, see, I don't feel like that, and in fact, that for IUD and implant need to go through the company's training and certify.
For
And you
implant,
do
yeah.
the step shot, you don't need to, you just
Yeah.
get it. So for those people who are not really comfortable to do IUD or implant, they can choose not to go through the process, training process and get the certificate. So they just refer the cases to OB/GYN or whatever want to do that.
That's true for implant for all provider types, regardless of providers. Yeah, so we know that's a barrier to being able to provide implants is you have to do a manufacturer specific training as opposed to you can learn it in residency or clinical education. Is another question.
I guess I'm curious, have you been able to look at the distribution of the numbers of prescriptions at the provider level? And I guess that is particularly for the previous slide where you gave, I thought that was really interesting to think about the share of total providers in each of these categories. Does that look different if you do the share of total patients
Yeah.
who are provided?
Well, I will say on the previous slide and then a later thing that I'll show if we have time, we set a minimum volume threshold of 10 prescriptions per year, which isn't actually that many, right? But we had a surprising number of people in the data who were doing 1 or 2 or 3. And so we decided to drop those people because potentially they're either prescribing outside of the scope of their regular practice for whatever reason. But we haven't done that much more sort of volume analysis other than that to use that sort of as a threshold.
Yeah, I'd be curious, because I assume there's a pretty
Yeah.
wide distribution, and those percentages might be quite a bit different. If you look at the patient.
Yes, I think so. For an analysis that we have underway right now, I don't have the exact numbers off the top of my head, but we looked at volume for OB/GYN compared to family medicine, and that average is something like don't quote me on this because we're in the middle of doing it, but it was, I'm going to say over 50 for OB/GYNs, and for family medicine, it was maybe more like 12 to 15 kind of at the year level. But we haven't actually done that in a systematic way.
And what's the nurse practitioners that have to actually wonder
Oh, yeah.
whether they wouldn't have.
Yeah. And we haven't done that yet, but interesting. And then the other finding that I wanted to highlight from this paper in particular, and so again, for IQVIA, we have commercial insurance, Medicaid, and other payer mix in there as well. We just focused on prescription contraception because of the tiers issue. We wanted to use the data set where we had the most reliable data quality and didn't have sort of missing data. So we looked by specialty and then by state. I know you cannot read what all of these states are, but just to say that the sort of solid line here is states that have expanded Medicaid, and this kind of hash mark line is ones that have not expanded Medicaid. So you can see that even though there's a little bit of variation across states for OB/GYN, it's about 85% to nearly 100% that are accepting Medicaid. When we look at APRNs and nurse midwives, we see pretty high percentages, but a little bit lower than for OB/GYNs. For family medicine, kind of similar to APRNs and nurse midwives. And when we look at internal medicine, we see that it's lower overall, but we also see much more of a differentiation between states that expanded Medicaid and states that haven't. And this is something that we're hoping to get into a little bit more with our Medicaid data, but this was sort of a first look at the state level about what's going on.
Yes.
So the guess is, our guess, we don't know why, we couldn't study it, but the best guess is that a lot of OB/GYNs accept Medicaid for birth, basically, for delivery related care. And so if you're already a Medicaid provider, you're probably providing services to Medicaid beneficiaries anyway. And for internal medicine, you might not be as likely to be providing the type of care where you need to sort of accept Medicaid. And also if you are referring out for sort of specialty services like OBGYN care, again, then you might be sort of less incentivized to accept Medicaid. I would love to know more, though. We haven't been able to sort of explore the why of any of it. Yeah.
Just to clarify, sorry, I'm not sure I understand what a number here means.
Yeah.
Can you just walk me?
So this is DC, which is not a state, but out of all of the OBGYNs in Washington, DC that are prescribing contraception, 85% or so of those are accepting Medicaid, billed Medicaid for one of their prescription contraception. And then does that help?
Yes.
Yeah.
And also one comment, a lot of time that after delivery within 6 weeks, we just put in IUDs or implements on site 2 days before the women's discharge. So that might be the timing when the women put in the contraceptions.
Yeah. Is that I assume that's in California. So has California unbundled the payment then? Because I know that in a lot of states, there's this barrier of the payment being bundled. And so people cannot do immediate postpartum insertion of
It depends
either
on
IUD.
preferences. There's some of the people, well, it depends on how they do it. Because Medicaid sometimes they can unbundle it, and some cases they prefer not to. Depends on how the office operates.
Yeah.
But currently, because we are so afraid the patient is discharged and doesn't come back
Yeah.
from any contraception.
Sure.
Before the patient really go out of the hospital, we just do it.
Yeah. I think there's a lot of interest in that. I understand that in other states that it's been a barrier because they're not going to get reimbursement for it at the time of delivery.
That one outlier on the internal medicine.
I know.
Oh,
Curious.
this one?
Yeah.
That's Wisconsin. Again, I have no particular explanation for any particular state, but it does look interesting that you could see kind of this division, except for, what's happening in Wisconsin. So this is kind of as far as we understand, this is the first national look at the workforce that's providing contraception in the US. We wanted to do sort of a similar thing to understand who is providing abortion care in the US. Now, on the abortion side, we have a couple of challenges to using claims data, the same challenges with IQVIA related to the provider tiers, but also we know that most people don't bill insurance for their abortion services. So we are not capturing the full universe of abortion care in the United States. But to be counted basically in this workforce, you have to have provided a single abortion in the course of the year and build it to either insurance or Medicaid, which is less likely, but to build it and be in the claims data.
Why do most people not bill insurance?
Privacy concerns, it's not covered. I think those are the main reasons, but that's not our research. That's Guttmacher, and I think other institutions have sort of found that pretty universally. So, again, sort of the theory is that access depends a lot on the workforce. In particular, a lot of the workforce research in the past on abortions has counted sort of one provider as one facility, whether that is UCLA's entire OBGYN department, that's one facility. Your family planning clinic down the street that has 2 docs is one facility. And so you're missing some of that sort of variation and probably failing to capture individual clinicians, maybe primary care docs who provide abortion care to their own patients and aren't necessarily in sort of specialty settings. So we wanted to understand, again, sort of the national workforce, but specifically to think about a provider equals one person. Also, because we're using claims data and we know that it's the same set of clinical skills, the same set of procedures and same set of medications that are used to provide abortion care as to provide care for miscarriage management and other early pregnancy loss management. We wanted to see how those workforces look different. Again, this is from the paper, from the table, from the paper, but I'm going to walk through it. So our sample size is much smaller here, but it's still, as far as we understand, sort of the first national look at this workforce. We have about 23,000 clinicians, that are providing either abortion care or pregnancy loss management or both, and also are billing insurance for that care. So we found about 3,500 providers of induced abortion and about 22,000 providers of pregnancy loss management. And on the next slide, I'm going to show the overlap, but I want to again walk through sort of the differences by specialty. So again, we were expecting OBGYNs to have a high number. We are only showing numbers here and not proportions because we know that we're missing a lot of abortion services. And then again, because of this tiers issue, we wanted to include as many people as we possibly could. We found 4 emergency medicine providers. It's not a lot, but it was more than 0. And I think that was kind of an interesting finding. About 250 family medicine. I can keep stepping on this. No, it's fine. I'm just a pacer. 1 general surgeon, 13 OBGYN specialties, which includes maternal fetal medicine, and others that are not sort of in that general OBGYN category, 24 internal medicine, and 17 pediatricians. Yeah.
So just remind me, so this is in the United States, a whole wide period, so there's 3,500.
Yes.
Providers.
Calendar year 2019.
Sorry?
This is just for 2019.
Induced abortions is really count as miscarriage, or is it only abortion process or procedure done in the hospital or outside clinic? Because you're gonna do the medical abortions miscarriage or that usually in clinic and bring the medicine back home. So even though it counts as a medical abortion, but it's also induced. So I don't know. You define that.
Yeah, so induced abortion includes medication abortion. So we have both mifepristone and misoprostol in here, and then DNC, DNE services. And the way we differentiated between induced abortion and pregnancy loss, which is the next one I'll show, is by ICD-10 code. So we saw what the diagnosis was for and sort of what the indication was for.
Is there misclassification of that?
That's a great question.
I'm just wondering if the
I'm
level
sure
of
I'm gonna-
misclassification, also depending on social and political status within the state.
A great question. And I'm also sure that it would look different in 2022, right?
Right.
Than in
It's
2019.
interesting to do. Yeah.
But I would not imply that anyone is committing any.
Right.
Okay.
Yeah.
I'm just curious, since these don't total 3,500, what are the other specialties that make up the rest of that 3,500 providers?
I probably would have to go back and like pull the full list of them, but we have, so when we got the data from IQVIA, the list of specialties, there were about 280, I think, total specialties that they gave us. And so for most of our analyses, like we're focusing specifically on these ones, and then everybody else kind of gets lumped into an other because there was 1 radiologist and whatever other thing. So I could look and find you the full list of the other ones if you're curious. I'm going to show the numbers for pregnancy loss management as well. So similar number of OBGYNs providing care for pregnancy loss management, a lot more emergency medicine physicians, which is possibly not that surprising since people may be presenting to the ED for these type of services. Lower number of family medicine physicians, same number of general surgeons, and similar number of OBGYN specialty. And I'll just show all of them. So I think, and maybe to get to someone's question, the other, this isn't in the paper, but we just did this because we were curious to see the overlap of providers. Oh, to get to your question. Who is providing induced abortion only, who is providing pregnancy loss management, and who is providing both services. So we know that these services are often treated differently in a policy context, in a political context, and that people may feel, there may be some sort of billing issues going on. But we also know that there's a phenomenon where providers will only provide management of pregnancy loss and will not necessarily provide induced abortion, will refer someone else for that. And so we wanted to see kind of what the overlap is between these two. And so you can see much higher proportion of clinicians providing pregnancy loss management services. So this is using our 2019 data. We got 2020 data. 2020 was a strange year for the workforce for many, many reasons. So we sort of sat on our 2020 data, and using our 2021 data, we wanted to see what happened to this workforce during COVID. So there was, you may remember, back in March, April, May of 2020, there was a lot of concerns about access to healthcare services. A lot of doctors' offices were closed. People couldn't get in to see their doctors. But there was also concern about sort of workforce exit, the idea that providers would say, there's too much stress on me, there's too much strain, completely understandably, and say, I'm retiring early, I'm moving into a different line of work, I'm going to work for policy or pharma. And so we wanted to see kind of look at this over and change over time. Particularly for abortion procedures in those early months of COVID, a number of states, mostly sort of red states, had classified abortion as an elective procedure. And in the early days of COVID, there was a pause on all elective procedures. And so we were curious to see whether people were still able to access abortion care kind of in that early period of COVID. So this is that like March 2020 through May 2020 period. This is looking at in-person contraception services, which we mean as services that you physically have to go see a provider to get. So that's IUD, implant, and the depot shot. We don't include prescription here because people were still able to get those, and people were still able to go to the pharmacies. They might have been able to have a telehealth appointment, but you cannot have a telehealth appointment to have an IV insertion. So we saw this huge dip, and then we saw it kind of rebound back to pre-COVID levels. For abortion, the numbers are lower, so I want to note that it's on a different scale. But what we found is we didn't see a big dip or a big spike in that March 2020 through May 2020 kind of period. We did see an increase sort of over time in medication abortions that was like slow but steady increase and a slow but steady decrease in procedural abortions. So that would be the sort of DNC services, MVA, D&E. That aligns with other research in the field that shows that medication abortion is sort of rising and prominence and also in particular coinciding with a decrease in procedural abortion. And then because we're trying to understand what happened with the workforce, we looked at and again, this is just straight counts, this is not proportions of providers over time in 2019, 2020, and 2021. And I just want to highlight two of these rows for you to look at. So for in-person contraception services, for physicians, we see this dip from 2019 to 2020. And then in 2021, it starts to rebound a little bit, but it doesn't come back to that 2019 number. And this, we don't know why from this data, again, it's just observational, but it could be some of that sort of workforce exit that people were concerned about, providers deciding to retire early, switching to a different line of business, et cetera. When we look at the number of advanced practice clinicians during that same period, we see basically flat from 2019 to 2020 and then rising in 2021. And that is true across the board, I think, in workforce research, is that there's a lot more, there's the number and proportion of advanced practice clinicians that are providing services in primary care and reproductive health care is growing. And so I think this is a trend that we're expecting to see kind of continuing over time. So I'm going to switch now to talking about some of our Medicaid specific analyses that we've done. And then if there's time at the end, we'll come back to one related to IQVIA. So the sort of underlying issue that we're trying to understand here is about who's providing care to Medicaid beneficiaries as a health equity issue. Looking at the number and type and distribution of providers, as well as the training they receive. So, yeah.
I'm sorry, I'm still ignorant, but in your previous slide, what is exactly an advanced practice clinician?
Oh, yeah, so it includes advanced practice nurses, so usually nurse practitioners, nurse midwives, and physician assistants. Okay. As I mentioned on an earlier slide, the TMSIS Medicaid claims data that we have. This is administrative data that comes from all states in the US. We have both medical and prescription claims that are identified at the provider level and at the patient level. So this is slightly different from the IQVIA data. There's a little bit of a lag time in when that data becomes available. So we have the paper that I'll talk about here was using 2019 data that just came out in August, and we're in the process of cleaning and analyzing the 2020 data. The data quality varies a lot by state and the particular indicator that you're looking at. So this is from DQ, the data comes from the Medicaid claims that are submitted by each state. And so this is not our data, this is DQ Atlas, which has all of these different measures here of data quality by state, and green is good and red is bad. And so you can see this is for the NPI of the billing provider on each particular claim, and it's pretty good across states. But when you look at the servicing provider, which we know might be different, again, related to the question about advanced practice clinicians who might be the servicing provider, but the billing provider is a physician, then we see that there's a lot more variation here. And so depending on the particular question that you're asking, there are, I don't know, 15 or so more of these. And so our team has done a ton of sort of behind the scenes work of going through and cleaning and classifying states into essentially usable data quality versus not usable data quality for the workforce related analyses that we're doing. I think there's more and more interest in the TMSIS data compared to the IQVIA data and some other data sets. It's actually not that expensive. It's a little bit harder to sort of manipulate, and there is this lag time, but I think more people are becoming kind of familiar with the TMSIS data and using it for these type of studies. So we wanted, for this one, we wanted to look specifically just at family medicine physicians. And we wanted to understand the relationship between residency training and the current services that they provide to Medicaid beneficiaries. So we know from our past work, as well as another paper that I haven't shared here, but is available, that about half of primary care physicians provide prescription contraception, but only 10% or so provide IUD and implant to Medicaid beneficiaries. So that's a big gap. And we know, again, from other research that residency training for physicians has been shown to sort of imprint on their practice behaviors, including where they practice, what services they provide, and particularly whether they accept Medicaid care. So I just realized I have this, I think this should be on the next slide, sorry. So what we wanted to study was family medicine physicians who completed their residency training between 2008 and 2018. We gave ourselves 10 years so that we could have a big enough sample size. But we also wanted folks who had completed their residency training sort of in a timely way that it would be relevant to the type of practice that they provided in 2019. So we used, and then they had to also be treating just at least one Medicaid beneficiary in 2019 for any type of service. That's our study population. We use the TMSIS data, using that based on the sort of the data quality issues that I mentioned earlier. We are using data from 43 states and DC, so it's nearly national sample. It's as close to national as we can get. We are also using the American Medical Association master file and historical residency file, which tells us what residency training they did and what year they graduated. And then someone asked this earlier when we were talking, but we can crosswalk the AMA master file and the TMSIS data, as well as the IQVIA data, because they all have provider NPI, that national provider identifier. And so we can actually see which person attended which residency training and then what services they provided. So we conducted a logistic regression model. We have a number of control variables, which I'll mention briefly. But the outcomes these are all of our control variables, and I'm happy to talk about them if you like, but these are the outcomes that we wanted to measure. Prescribing pill patch and a ring, IUD and or implant services, and then dilation and curettage, which is also DNC. That's what my, I think, floating asterisk there was. And I think I've mentioned this before, but DNC is a procedure that can be used for abortion care, is also used for management of pregnancy loss care. So because we're talking about Medicaid data, most states do not allow for abortion to be covered in Medicaid claims. So we weren't expecting to have a lot of abortion care, but miscarriage management should be covered by abortion. And so we were expecting to find some level of DNC, and we did not put that same requirement as we had for the previous analysis, that it had to, based on the ICD-10, that it had to be based on a specific diagnosis. So it's DNC for any reason. There are two residency training models that we're particularly interested in. The Teaching Health Center model. So Teaching Health Center program was created through the Affordable Care Act. The Teaching Health Center residencies have the same residency requirements as any hospital-based residency. but the primary training location has to be a community-based setting. So typically it's a federally qualified health center or a rural health center. And so we know from other research that graduates of teaching health center programs are more likely to provide care to Medicaid populations, more likely to see underserved patients in general. And so we wanted to look at this because we're looking at Medicaid population. We also wanted to look at the Reproductive Health Education and Family Medicine, or READY program, which includes opt-out training for abortion, pregnancy loss management, contraception, and other reproductive health care, to see if those graduates, again, were more likely to provide these reproductive health services. These are the papers, these are tables from the paper. I'm going to just show some of the kind of high-level findings. So we had 21,904 family medicine graduates from 410 family medicine residency programs in the US. And again, we're providing services to at least one Medicaid beneficiary. About half were female, 16% practiced in a rural county in their current practice location. A little over half had completed residency over 5 years ago. And then 7% were ready graduates and 3.5% were teaching health center graduates. So first, we found that about 61% were providing prescription contraception. That's pretty similar to our other research that we found. A much lower percent were providing IUD and implant, about 18.5%, and then less than 1% were providing DNC services. And then when we, in our regression model, when we accounted for these various factors that are all listed down here at the end, these are sort of our high-level findings on residency training. So you can see that ready graduates are more likely for all three of our outcomes of interest compared to non-ready graduates to provide these services. For teaching health center grads, we didn't find anything statistically significantly different for pill, patch, and ring or for DNC, but we did find a higher likelihood for IUD and implant, which is a finding I'd like to sort of study more. In general, we know that teaching health center grads are more likely to provide care to Medicaid beneficiaries, but there's not a specific component of reproductive health education there. So I'd be curious to know more about that. And then we also looked at residency program size. So you can see these are compared to residency programs that have 11 people or more. So you can see that smaller programs like 1 to 5 residents were less likely to provide IUD and implant and DNC services, and residency programs that are sort of medium sized were less likely to provide DNC as well. So this is sort of where I hope we're going with this research, is to be able to explore some of these more kind of particular factors that may be associated with the scope of services that this workforce is providing, who they're providing services to. So the last thing that I wanted to share is we know we're looking nationally. Yeah.
Sorry, I maybe missed this, but why didn't you include induced abortion in this research?
In this
Why is there
one,
only DNC here and not like?
we didn't exclude induced abortion. We just didn't differentiate between DNCs provided for induced versus DNCs provided for pregnancy loss management.
Okay.
Because most states, so California is lovely, but most states do not cover abortion care in their Medicaid programs. And so we weren't expecting to pick up a lot of abortion services across the US. And I think in an early analysis, we looked at it and the numbers were so low that we had to sort of group everything together. Yes, I think there was overlap. I have to go back and check whether we looked at that particular correlation, but I know in general that is true, that the smaller programs tend to be more weight.
The top two comparison, or what's the comparison group? Is it like the ready graduates versus all other residencies?
Yes.
So it would include
Non-ready.
teaching.
Yes. So we've been talking about this at a national level. We will continue to study this at a national level, but we also understand that workforce is local to the people who are trying to access care. So the other thing that we wanted to do, going back to our IQVIA data, is we have what we call a workforce tracker, which shows the ratio of the providers that are prescribing contraception. Again, we're just using our prescription data because that's our strongest data here, compared to the population of women of reproductive age. We have it at the state level. California, we are missing Kaiser, so I would like to say that, but also California is a very big state. And so it's unusual to see California and, for example, Texas sort of in the same category of things related to reproductive health. I will say that New York is also in that same category. This is a screenshot. So this is interactive. It's on our website. You can play around with it. You can turn on or off any of these provider types. You can look at different years and see how it changed over time. We also have it at the county level. So I feel like I pick on Texas a lot, but it's a very recognizable state shape. And so you can see how the whole state was yellow when we look at it. But there are sort of these areas of dark green, which means that are higher provider density. But if you live in one of these counties, now I know population is low here, you have to travel across probably 5 counties to be able to even see a provider who will prescribe contraception for you. We're planning to update this with 2022 data at any minute now, and it's going to look a little bit different. Oh, here's California, if you'd like to see it, some other states that are recognizable state shapes. Because, in part because the IQVIA data is so expensive, but also because we like to do things that are useful to other people, we have made it available to request this data. The request form is like name, email, and a couple of other things. We just want to make sure that you're not going to use it sort of for bad purposes, but it's available to students, faculty, anybody who wants to get it. You just have to submit this request form. It's a de-identified version of the data set. And so it is literally a row for every county in the US by provider type and whether they are prescribing contraception or not. So you can use it for state level analysis, for national level analysis. We have all 3 years of the data in there right now, and we'll be putting 2022 in soon.
Just the California one, sort of the big patch of yellow in the bottom, that means there's no providers in that whole section.
It doesn't mean no providers. It's just the lowest ratio of providers to population by quartile. So I will say one of the updates we made with our 2022 data, which is not live yet, but again, like hopefully any minute now, is to add a 5th category of no providers versus the lowest number of providers.
Yeah. Okay.
Yeah. So I decided to do my discussion sort of all together for everything all at once. So I first want to say this is not a blame game for the people who are not providing these services. We are not saying, why aren't you doing these things? But instead sort of, how can providers get the training and the support that they need to be able to offer these services? In particular for primary care, especially in rural and underserved areas, they may be the only provider that a person can see. They may be the only one that is accepting Medicaid, but they're also facing sort of this growing set of pressures to include all types of services. You're supposed to add mental health screenings into your counseling now, and also contraceptive counseling, and also COVID happened, and jobs. And so there are all these kind of pressures that are mounting on this workforce kind of at the same time. So again, sort of being able to offer provider support that they need to be able to offer this care. One of the particular ways to do that would be to strengthen training as well as accreditation requirements for multiple provider types. So for OBGYNs, they're required to get abortion training, but family medicine are not. And so you have programs like READY, which we show, are associated with higher provision of the type of skills that you need to be able to provide abortions, but the READY program is not every single family medicine program in the country. We talked a little bit about scope of practice restrictions for advanced practice providers. And so moving some of those unnecessary barriers and being able to provide those services without physician supervision could potentially expand this workforce. That is an expanding segment of the workforce anyway. And then of course I have to mention, because of jobs, there are mounting set of restrictions on the workforce that can provide abortion care, especially in states that have significant policy restrictions. So what are we doing next? 2022 was a big year for reproductive health. So we are working through our 2020 data right now. We want to see what changed. We want to see if we see a shift in provider types. For example, one of the things I'm curious about, but we don't know yet, is do we see more emergency medicine than we have in the past because more people are presenting to emergency departments? And how does that shift happen? We were talking earlier about closures of OB units and rural hospital closures. And do we see that, sort of this exodus of OBGYNs out of certain states? That's something we're also kind of curious about. And then I hope that we'll be able to continue to explore sort of various policy factors, clinician level factors, community factors in a shifting landscape of reproductive healthcare. This is our team, which used to include Rachel, who is here. This is our website. All of our papers are on there. The contraception tracker that I shared earlier is on there as well. And I know people have asked questions, but I save some time for questions now. Additional questions? Yeah.
So does this allow something to like Planned Parenthood offices or like?
Yes.
Okay.
If they can bill insurance, so on the IQVIA side, if they can bill insurance, whether it's commercial insurance or Medicaid, they're in here. We did do an analysis earlier of how many sort of women's health specific or family planning specific clinics were included, and I think we're capturing most of the Planned Parenthoods in the US that we could find. That was looking at our 2019 data, but I think we're capturing most of them.
They all don't matter.
Yeah, they help bill somebody, yeah. Yeah.
I wonder if there are any plans to kind of, I know your research is focused on the healthcare workforce, but I wonder, especially thinking about abortion care, if there's any plans to kind of contextualize this with data on abortion, more like hidden abortion data or abortion, you know, from people who are self-managing abortions in the US. I think it would be really interesting to contextualize with that data as we see the changes and see how it changes in that sector.
Yeah, I think self-managed abortion is kind of the question that we get like a lot, and there's no way we're gonna be able to capture that with claims data, right? But I think especially in light of jobs, there's gonna be more and more people who choose self-managed abortion. And I think there's also a lot of interest in protecting those folks' privacy in particular, you know, it's sort of even more so in a way because people choose self-managed abortion either because they're in a restrictive state or they have privacy concerns about their partner or their, you know, family situation or kind of whatever else might be going on. So I think there's a lot of talk about how to understand that, but sort of
Easier said than done.
yeah, well, just concerns about how to do it in a way that's sort of ethical and respectful. But I think it'll be interesting.
In the IQVIA data, can you look at whether the medication abortions were provided via telehealth versus clinic-based?
So we can, but one of the things we were hoping to, but kind of couldn't do is see what services are provided via telehealth. So providers had to indicate like a specific code that as a telehealth code. And so we looked at the number of telehealth services in 2020 in particular, because so much more telehealth sort of started happening in early COVID. And the numbers were so low as to be basically not believable. So we didn't do any analysis related to telehealth. And we understand from conversations with folks that sort of adding a second code onto the other codes that you've already done might be something that people are skipping. And so with this particular data, I don't think we have a good look at telehealth services, which sort of, we have them in there. It's just hard for us to necessarily say 50% of these services were done via telehealth, because when we looked at, I think it was 10% of them, you know, in March of 2020, and we said basically like, that's not possible. Yeah.
But for at least telemedicine abortion, it would have been a little bit later in 2020 that the REMS was removed.
Oh, yeah. Oh, yes. So yes. So once the REMS was waived, we thought we might pick up. So mifepristone is in our data on the medical claims side. It's not on the prescription claims side, even though it's a medication. Yes, we looked in the data to see, because we thought it would be once they waive the REMS that maybe in the later half of 2020 that we'd pick it up more in the prescription data, and the numbers were basically also so low. And again, just through sort of conversations with folks about like, why do you think this is? Because we thought this was really going to change. What we've heard anecdotally is that pharmacies would have had to stock it, and that sort of wasn't necessarily happening. And so most providers just continued to offer it sort of in office the same way that had been before the REMS was waived.
Can you just tell?
Yes.
What the REMS are?
The REMS stands for Risk Evaluation and Mitigation Strategy, and it's a particular requirement that was imposed on mifepristone, which is the first medication in a medication abortion procedure. When FDA approved mifepristone, it instituted this REMS requirement that people have to come in clinic to receive the medication, as opposed to being able to get it as a prescription like you would with most other prescription medications. But during 6-ish months of 2020, the REMS was waived because of the public health emergency during COVID, and this having this sort of requirement to physically be in a provider's office during the peak COVID or whatever we want to call that time. There was concerns about COVID exposure, right? And so the REMS was temporarily waived, and then it was reinstated later.
Found that there was no empirical evidence for the REMS in the first
Yes.
place. But yeah.
Yes, also that.
Yeah, I just want to comment on paying attention for those yellow square boxes. Is that where they might not have that amount of the contraception provider, it depends on the area, if you can get the zip code. Because a lot of times that those areas are highly concentrated with conservative populations, which means that their backgrounds or religions that are not believing in contraception. For those kids or women's need to go outside of that county to getting providers.
Yeah, we do have it at the zip code level. We have sort of hard to, we didn't display it at the zip code level, but yeah, I understand. I mean, the people wanting to travel away from sort of their home base to be able to get there. Yeah.
We kind of one comment, but were things like birth control pills or after the day after pill or basically pills, why do they have to be prescribed? Not in all countries, they have to be.
So it's different for emergency contraception or the morning after pill than it is for oral contraception. And FDA in July of this year approved the first ever over-the-counter oral contraception. So the rollout should happen, I don't know, soon, I think, but it's not yet available, but should be available. I will say for that one, it is specifically is only the progesterone only pill. It's not the combined oral contraceptive, which is what most people choose. My understanding about that was that the sort of safety profile of it is a little bit better. And so advocates who were pushing for this to be available over the counter kind of wanted to start with that. And then the next step is to go to the combined oral contraceptive. So there's no medical, to answer your question, like there's no medical reason. I think it should be available over the counter, and hopefully that's where we're going. We have taken this sort of like baby step. And then on the emergency contraception side, so there is some prescription emergency contraception. That's the brand name Ella. It is effective for a few more days than the over-the-counter version. They've also done studies, I think, in people of varying body sizes, and so people might prefer to choose that. I will say we haven't included data on emergency contraception in any of our stuff because so much of it is accessed in over-the-counter or sort of behind the counter. We kind of have talked about it, but I think we'd be capturing such a small proportion of that particular service. And also because we're looking at it from the workforce side of things, there are probably not that many folks who are prescribing only emergency contraception and not doing any of these other things. I mean, there might be some, but I don't think we'd probably be capturing that many more providers. Yes.
Kind of along these lines, but speaking to other services, I'm thinking about, I guess, have you all gotten any attention from folks who are trying to expand scopes of practice to other providers for varying services? Like I'm trying to think of, I don't know, if you've been reached out to by folks who are trying to, I guess, expand who can offer what services, and if you think that there's generally greater attention to certain, like expanding.
Meaning like folks who want to sort of advocate for fewer scope of practice restrictions on advanced practice clinicians, or
even in a state where we still have gaps in who's allowed to prescribe.
No,
I guess, but
we have, well, no, not, so to answer your question, not really, people haven't asked us about that. I know we were talking about this earlier, but we've gotten a couple of questions about doing something similar for the maternity care workforce and like knowing that there's overlap there. I think those are more of the type of questions that we get, and also seeing what happened post-op. I think there's a lot of like hunger for information about what happened after adoption, because getting real-time large-scale data available is so tricky. You know, I think those are kind of the questions we get more.
And you could also track using that NPI number, like if physicians are leaving, so like what we've all been reading about what's going on in Idaho, for example, right? Like you could track where they go.
It's hard. We've been working on it for a couple of months. I would really like to, I wish that I had something that we could share for that, but the challenge is, for the IQVIA data, we have the tiers issue. So unless they're a tier 1 provider consistently every single month, for all of 2022. It's a little bit harder for us to say that. And then also because the way that we requested the data from IQVIA was to give them a list of services. So we don't have the full scope of services that every provider is doing. We know whether they're doing IUD, implant, abortion, et cetera. And so you might be a provider who does 5 abortions, 5 IUDs in a year, but it's just because you haven't done them in those last 6 months of 2022, it's a little bit harder to sort of assert that you've fully dropped out of the workforce or that you've sort of moved. So we're kind of exploring other ways that we might be able to answer that question. We were hoping to be able to do it with the prescription data, but because there's so much volume fluctuation kind of by month, again, that was harder than what we had hoped. But I hope we'll have something, so.
Stay tuned.
Stay tuned, yes.
Does the IQVIA data include pre-hospital records, so particularly for pregnancy loss?
But what do you mean did you say pre-hospital?
Pre-hospital, so emergency medical services provided like before the
Oh.
emergency.
I don't think so, because I don't think, unless they would, I mean, if they have a medical claim associated with it, then yes. If it's, and it would also have to be on our list of services that we asked for. So if it's just emergent. So one of the things that we realized we couldn't ask for is all evaluation and management visits in the US. So a lot of times people will not necessarily come in for a contraceptive management visit, but they'll be in for their regular annual exam, or they'll be in because they have the flu and we'll ask for a refill on their pill prescription. So we wanted to get all of the visits we could get our hands on, but it was prohibitively expensive for us to get all of the visit types that were available. So we sort of have a workaround for that. So anyway, that's to say, unless it was on our specific list of services that we were asking for, we might not have it. But if they had anything to do, yeah, I'm trying to think if there'd be any pre-hospital, because they wouldn't have a CPT code. I think it's unlikely. I could poke around and find out, but I think it's unlikely we'd have most of those because it wouldn't be in an office, like in a provider's office.